our podcast, Fixing Healthcare from the Trenches, where we bring people, mostly clinicians, who have done and are doing innovative things to try to actually bring sense back to our U.S. healthcare system, whether it be efficiency, the quality, and really trying to bring the cost down. And that requires this kind of collaboration and information. So this week, I'm particularly honored to have two colleagues, one a fellow orthopedic hand surgeon that we actually had a company together called American Hand Institute. We had 2 patents for small joint devices, very interesting things that we did together. And Steve Topper is joining us and is now involved in a company, a private equity firm that is focused on lower and middle market healthcare solutions. And I'm also joined this week by his colleague, his partner, Sonia Ponnusamy, who is a Harvard and Wharton MBA and has done significant work in a number of areas, including investment banking, private equity in the UK, Hong Kong, and has been since 2017 focused on healthcare and really bringing solutions, because I think we all need them. Would you agree, folks, that we need some solutions?
Absolutely.
So tell us about your firm. Steve, why don't you start and tell us how you ended up meeting Sonia and how you joined and what your goals are?
Yeah. Well, I was introduced to Sonia by a mutual friend. When I heard about what they were doing with their private equity company, which is called Aspire Physician Solutions, their model of how they're doing this just it made me ask myself the question, where were you guys when I needed you? Because Alejandro, I think you and I are roughly the same age. I may be a year or two older, but what I've seen happen over the 30-year career that I have is I've just seen reimbursements go down while costs continue to go up, and it's making it absolutely so hard for private practice physicians to stay in practice. And when you think about how they are sandwiched between medical practice groups or large insurance companies or hospital systems that are driving physicians out of, because of market forces, they're driving physicians out of private practice into these, aggregate models. You just think that the physicians, in order to survive, they need an ally to come alongside and provide some power and some capital and some expertise to help them survive the pressures that they're facing. And I think having an ally like that and having a plan is a very very smart strategy to deal with how the healthcare market is today.
So Sonia, as you know, there's physicians for a long time now have had concerns, right, about private equity, venture capital, et cetera, getting into healthcare. But Dr. Topper sees a real potential for disrupting what's happening right now, which is big healthcare systems and even insurance carriers kind of dominating healthcare. So what do you see your firm doing that's going to be different?
Well, I think private equity offers a lot of really unique solutions that are really not open to physicians if they remain in independent practice. So I think you can kind of bucket those into 3 main categories. Firstly, it's the ability to really monetize the true value of your medical practice, all those years of training, all those years of looking after patients. So in the private equity model, you get an upfront lump payment, and then you get this thing that's called the second bite of the apple, which is in 4 or 5 years when the practice is sold for a second time. And both those events are taxed at the long-term capital gains rate tax rather than ordinary income, which is 20% rather than what in some states can be 45%. So it's an ability to sort of take some of your chips off the table, take some cash when you close, depending on where you are in your life cycle, and opportunity for some of the younger doctors to pay off the medical school debt, or some of the more senior doctors to diversify their wealth. And then, and also in terms of sort of downside protection, if you've done this deal, say something terrible happens, such as disability or death, et cetera, the value of your equity is much higher than if you'd stayed in independent practice. And also, private equity is a meritocracy. Obviously, physicians are always concerned that if we partner up with a private equity firm, what does that mean in terms of compensation? Well, your compensation under a private equity model is based on your productivity. It's a percentage of collection. So, there's not really something to fear there. But also, we've talked about how challenging the healthcare industry is, and particularly challenging if you're a small independent practitioner. So it's, being part of a larger group, having more purchasing power helps to safeguard against sort of future risks and uncertainties. So things like changes in reimbursement, more competition from hospitals and health systems, your referral sources are being bought up by hospitals, continuing shift to value-based payment, growth of direct contracting with self-insured employers. If you're a small physician group, you don't have, the scale to be part of that conversation in terms of negotiation.
Sounds like you're able to level the playing field, correct? Because you now have this partner that has a capital access to capital. The physicians hopefully will be able to continue to do what they do best, which is practice medicine, in our case, orthopedic surgery. But you would be able to bring these resources and the business knowledge, right? Which admittedly, many of us just don't have. I mean, I never got an MBA, and it's a sort of school of hard knocks, but that's not really enough, is it? And to be able to compete with a large healthcare system that's really employing physicians, I think this is a good way to stay somewhat independent, is it not?
Yeah, and I think, you touched upon some important points, and what is, I believe, sort of the third key factor in terms of why independent physicians should look to partner with private equity is that there are an enormous amount of benefits of having this bigger corporate infrastructure. You can have best-in-class IT, best-in-class EMR. You've got, you get to have a real management team, really sophisticated corporate executives stewarding the business, cost savings. So all of that is important. And, as you said, you didn't go to medical school. You went to medical school. You didn't do an MBA. Yeah. There's a reason for that. You wanted to focus on practicing medicine. And I think there are lifestyle benefits of partnering, which is that you do get to focus on practicing medicine. It's less stressful. You don't have to have all of those risks and stress of being an owner of the business. You're not wearing 10 hats. You don't have to be head of IT, head of accounting, head of marketing. Somebody else does that. And I think in terms of what is unique with Aspire in our business is that we offer those opportunities to smaller businesses. So we will take businesses that are as small as 2 to 3 million of EBITDA, and those can be the initial platform. I think the other thing that's differentiated is that, not all equity is equal. When we partner with physicians, there's only one class of equity. The physicians, us, and the management team all have the same class of equity. The physicians are not subordinate in some way. It's not phantom equity. So I think it's really important to also understand the nuances, and that private equity is an incredibly broad term. And under that umbrella, there are a lot of very different models.
So Steve, having essentially left clinical practice, I mean, you see this as an opportunity to really make a change in healthcare, correct? I mean, it's and what led you to see, to work with Aspire when, let's face it, there is 13 or 14, I believe, private equity companies in the orthopedic space with these sort of MSOs. I mean, what led you to partner up with Aspire?
Well, basically, it's their model. Sonia and I did we did a conference in Chicago recently at one of the Becker meetings. And it's interesting, I was on a panel with a bunch of investment bankers, and the amount of equity that they skim off the top, or the what do you call it, Sonia? The
scrape, income scrape, yeah.
The income scrape was way higher than anything that we do, and the other thing is that Sonia mentioned, not all equity is equal, and our equity is what is called pari passu, or exactly the same for all the parties that are involved. And so I think that there are ways to do private equity that are more physician friendly than other ways, and this is the most physician friendly way of doing private equity that I've seen.
Terrific. Well, yes, I mean, I think, well, you know what I've gone through with my kind of disruption in healthcare, and it's been very difficult because many of these companies seem very much focused on the big EBITDA, or rather than what the actual innovation is. I mean, how good is the widget, not how many there are, and you decide to just buy them and expand. Why not take a very innovative idea that is, initially inexpensive, and just grow it something big? And that requires, I think, a more forward-thinking company like yours. And maybe this is kind of what's needed to disrupt healthcare, because right now it just seems like it's every day you read about these billion-dollar mergers and purchases. But I just wonder, is that, I mean, it's certainly changing healthcare. The question is it really making it more efficient and cost-effective in the long run? Because you're adding a lot of people to the equation now that also, need to put food on the table, right? So it's not just the people delivering healthcare, and that's fine for all the reasons that Sonia mentioned. But I think we have to find a really good balance here. Yeah,
and I think that clearly, with one of the big advantages of private equity is that there's economies of scale, and so you're doing this across a platform. So I think that that in terms of driving costs down, that could very well play into that, and so that's
well, this may be one of the initiatives, but at this point, generally in the podcast, I really want to know from our guests, what would be 3 initiatives, straightforward things that you think could really lower healthcare costs in the U.S., which, as you know, are not sustainable the way they are. What would you think? Number 1, Steve.
Closed networks are anti-competitive.
Okay.
And
eliminate that.
Right. So that would be, legislative in nature.
Yes.
But that anti-competitive behavior, it really does drive costs up. Yeah. And so that would be one that I would.
So there's a big move now to eliminate these, the non-competes and the restriction covenants and all, because is that related to what you're saying?
I'm actually talking about closed networks from hospital systems, insurance companies, etc.
Gotcha.
Mostly.
Okay. Yeah, that's incredibly costly, is when the patient's forced to go here just because it's this, instead of just saying, okay, what's the market willing to bear? If I can provide the service, why are we forcing them? Yeah, I live that every day with having an MRI machine here and saying, why are they going cross town when I could do it here for the same modest reimbursement anyway, right?
Right.
So, good point. Okay, so number 2, Sonia, what would you say is?
It's going back to what we've talked about previously, is that there's an enormous number of healthcare providers that are really small, 1, 2 practitioners in groups. It's a very fragmented space, and I think consolidation of those very fragmented providers in partnership with private equity, particularly folks such as ourselves that really specialize in working with these smaller groups, it offers benefits both for the patient and for the physicians, and cost benefits are part of that, and the scale that comes from combining.
Terrific. Okay, I can see that. And Steve, so third initiative.
So I'd say adding. So I think that we're going to see some big changes with artificial intelligence, And I know for a fact on the insurance company side, they're exploring, utilizing large language, artificial intelligence to streamline and also the pre-approval process, and also to deal with some of their costs in terms of employees, right? So I think one of the things would be, as we develop these electronic medical records, adding a AI component to that that's going to streamline the pre-authorization process, so that before this is even sent in, it's already run through the algorithms, so that the physician can know upfront whether it's going to be pre-approved or not, and if not, they can get whatever needs to be done so that could happen.
Yeah, complex stuff. I mean, certainly with the computer power we have, but in the end, what patients really want, right, is caring, and that physician relationship. It's one of the things that people worry about, understandably. As I've scaled down my practice, I'm spending more time with each patient, and it really is a pleasure. And I think with physicians, with reimbursement the way it is, the art of medicine has to be sacrosanct, and otherwise people are going to be continuing to retire early, and we have to do something to change that. So I hope that AI can really take the drudgery maybe out of some of the work, right?
Yeah.
So I'll tell you my three, which are actually pretty straightforward. It's the way I think. So I really believe that we need to get to a system where the patient sees the right specialist at the right time. I think a lot of cost, and that's one of the things behind ortho now, is that typically, and Steve, this as a hand surgeon, right? We are often the fourth physician seeing a patient. They may go first to an urgent care. That family practice doctor says, well, this is just a kind of walk in and you need to go to the ER. And then the ER says, well, this needs to be seen by ortho. And then your colleague says, well, I don't really do complex wrist. So now you need to see a Dr. Topper because he does hand and wrist, right? So now, but all three of those first steps have gotten paid, haven't they? And that's delayed the care. And in the worst scenario, and I have all kinds of data, including the Society of Military Orthopedic Surgeons, Steve, which you know something about.
Mm-hmm.
A very interesting study, showed how often in an ER there's an incorrect diagnosis orthopedically. So that just costs a ton of money. And the last one is what we're doing right now, and that's why I appreciate so much that both of you took time out from your busy schedules. It is public education. The challenge for us is now for the public to hear this and so many other dialogues that are out there about trying to fix healthcare. My modest, approach to this is writing a book, and that's what I did during the pandemic. In 10 weeks, I wrote this book, and the podcast came out of this because I realized that we have to collaborate, and I need to hear opinions. The closed network idea, Steve, is brilliant. Thanks for explaining it further. And we are hoping that perhaps the insurance carriers and, more important, the general public hears this, thinks about it, and contributes to us to try to really change healthcare. So any last words?
I was just going to say, it's been a pleasure being your colleague over all these years, and working together on some things. And I think we came up with some really good ideas.
Yeah.
As you know, I, having visited you there in Miami, I patterned a lot of my practice after what you were doing down there.
Oh, thank you, Steve. I appreciate that. And
I was unable to get out of network, though.
Well, yeah, that's that's a problem that most people have in the country, right? I'm lucky. I think that if you're in places like Miami or New York, where there is a lot of movement, more middle America, it's not going to be that way, and that's not fair, right? Because there's tremendous clinicians. I mean, I haven't heard from Dr. Tyson Cobb, but he's doing a lot of the amazing, things that we were doing, and it's a struggle. But I'm hoping that with these dialogues that we can really, level a playing field, and all ships rise in the tide. And I don't want to see U.S. healthcare really, what's happening now in the UK. Sonia can can talk about that. It's really dreadful what physicians are going through there. So hopefully all the pointers that you gave will be, somebody will hear this and decide to take action. And we're all here to help. Thank you very much, Sonia. Thank you.
Thank you, Alejandro, for hosting us. Appreciate it.
I appreciate it. So, well, we'll hear more from Aspire and see what we can do to really change healthcare. Until the